if that's okay. Welcome to the 7th Palliative webinar. The topic today is pediatric palliative care research in conflict settings, emerging evidence from the Middle East region. And we're absolutely delighted to have two colleagues who've worked on a major grant to share their experience. They'll explain the context, but it's a Middle Eastern context for this research today. We will host this webinar in a Zoom format, so there will be plenty of chance for discussion. Please put comments, thoughts in the chat as we go, and the recordings will be available later on the Palchase webinar. We'll introduce as we go. We've also got two panelists joining us in addition to the speakers later on, and we're delighted to have you all here. Yesterday's webinar, there was too much discussion. We were struggling to fit it all in. So this is a chance to think again about some of the issues that we covered and for all of you to contribute. We're hoping, very much hoping for no technical challenges today. So may I introduce our first speaker, Dr. Sabah Boufkhed, who gave a fantastic overview of this project and also of the setting in the Middle East. She's a lecturer in global health and director of the intercalated BSc in global health, an academic lead of HCRI public events based in the Humanitarian and Conflict Research Institute, University of Manchester, and also visiting researcher at Cicely Saunders. And it's great to have you. You've been part of this major grant with King's College, and we're looking forward to your overview. Thank you so much, Sabah.
Thank you, everyone. Thank you for being early morning. For my English in the morning, I have to say, is not as good as yesterday. I have to warn you. I'm just going to share my screen. Okay. I assume you can see this. So thank you, everyone, for being here this morning, and thank you for inviting us to talk about our research. So I'm going to talk about a research project that we've done in close collaboration when I was working at King's College London at the Cicely Saunders Institute. And the project was extremely collaborative. We worked hand in hand with Hacettepe University and King Hussein Cancer Center. And today we're going to talk about what matters to children and young people with advanced cancer in conflict-affected settings, focusing on Turkey and Jordan, where we have our great partner there. So I'm just going to give you a little bit of background. I'll be shorter than yesterday on pediatric palliative care and conflicts in the Middle East, then move a little bit through the methods we used and the aim of the project, share more about the findings, and then have a quick conclusion and perspective for the future on this topic. So in terms of study context, so as Moira was suggesting, this is part of a big grant called a bigger project called the Research for Health in Conflict in the Middle East and North Africa. And we, with Ghadeer, we focused on palliative care specifically for cancer. So as you may know, of course, like the Middle East and North Africa is a region affected by conflicts, and the one we talk a lot about are Syria, Libya, Afghanistan, Iraq, or Yemen. So what these conflicts imply for the region is that there's a lot of people who have to move, have to move within countries, within conflict-affected settings. So internally displaced people, but also have to cross border to flee and seek asylum in neighboring countries. So it has caused asylum seekers and refugees, and this has Turkey, Lebanon, Palestine, and Jordan are countries receiving asylum seekers and refugees. And I just want to highlight that Turkey and Jordan are some of the top host countries for refugees in the world. So what this conflict imply in terms of healthcare services? So conflict has impeded progress that was already being done before conflict. And in particular, cancer was being a priority, but conflict has shuffled the agendas in some of the countries in the region. The displacement of people has impacted care provision in the conflict setting areas, so in countries in conflict, but also for neighboring countries and host countries that are receiving people who need care. So cancer care is not covered by insurance for everyone in every countries, and humanitarian packages are generally not offering palliative care or cancer care support for refugees. There's another group of people in the region, so that are called therapeutic migrants, who are migrants who have to cross the border to seek for care in neighboring countries. And these also impact the healthcare services for neighboring countries. So conflict is bringing additional health challenges for countries, in particular for the diagnosis, management, and treatment of non-communicable diseases and palliative care. So in terms of palliative care in the region and more widely in low and middle income countries, so the vast majority of children with palliative care needs are in low and middle income countries. For the region specifically, cancer is the third leading cause of death among young people aged 5 to 14 in the Middle East. Each year in Jordan, there's close to 90 children per million who are diagnosed with cancer, and in Turkey, it's almost double, with around 160 children per million. In the region, palliative care is a relatively new development, and the access to palliative care is quite heterogeneous, and the provision of palliative care is not the same depending on the countries. No country has fully integrated palliative care within its health system. And one important thing for today's topic is that we know little about the potential contextual and cultural specificities of providing palliative care in the region for adults, but also for children. So on this map, you can see that the different level of palliative care development. So areas in gray, so in that yellow circle, which is more or less the Middle East region, you can see in gray countries where we have no idea if people have access to palliative care, so we don't record activity of palliative care. And lighter blue shades are for capacity building or isolated palliative care provision. And you can see there's a lot of them in the region. And the darker, the more integrated palliative care is for the region. So why researching palliative care, pediatric palliative care in the region? First, because we lack data in general on symptoms, concerns, and priority outcomes of care for children and young people with advanced cancer and their family in the region. Children and young people with palliative care needs are rarely directly asked about what they need and what are their priorities for their care. We, again, as I was saying, know little about the contextual and cultural specificities of delivering palliative care in the region, and we don't really know, on the top of it, what's happening for mobile population, so asylum seekers or internally displaced. So we need contextually and culturally relevant information on patients' needs, and we also need measures for quality patient-centered care. So our aim with this study was to actually address some of these gaps. So our big aim was to identify the palliative care concerns and needs of children and young people with advanced cancer and their families in the two countries, so in Jordan and Turkey. And so more specifically today, we're going to look at what matters to them and what are their needs and concerns. So to do that, the method we used was in-depth semi-structured interviews of 3 stakeholders groups. So children and young people with advanced cancer aged from 5 to 18, patient or caregivers of children with advanced cancer, but also palliative care staff in Jordan and Turkey. And by palliative care staff, we mean clinicians and non-clinicians. So also psychologists, social workers, and so on. As you know, palliative care is providing more than physical care. So the interviews were audio recorded by the teams specifically in Turkey and Jordan. So they are the one who did the hard work. Ghadeer is part of the team in Jordan. So interviews were audio recorded, transcribed verbatim, and then translated into English, and we coded in English. So because we had some complexity and because this was crucial to understand the cultural specificities, we adapted the framework analysis to be more collaborative and integrate the different perspectives of us. So because we are a diverse team with different gender, language, coming from different experiences and settings, we all generated themes at the beginning of a few interviews to generate themes. We also believe that this would address potential issues related to translation and content, understanding what people really meant. But we also use that approach, collaborative approach, to ensure a common understanding of the themes and the terms we used throughout the process and analysis. I just want to show you how it looked like. So this was done during some COVID lockdowns for some of us and some COVID sensitive settings. So that's the team that coded. So Turkey, Jordan, and me in the UK. Oops, sorry. So in terms of findings, so we had 104 participants. So it's a 50-50 split in both countries. In total, we had 50 children and young people. The median age was 13. We had roughly half girls and half boys. The main diagnosis categories were a malignant bone tumor, lymphoma, and leukemia overall on the sample in both countries. We had 30 caregivers. The majority were women, 70%, and the median age was 35. And we had 24 palliative care staff, aged a median of 32. Slightly a bit more than half were clinical staff, and the majority of palliative care staff were women, 75%. So what matters to children and their families? So we identified two groups of priorities and concerns. So one were the priority for palliative care outcomes, and most of those that we identified were similar to the one that WHO definition suggests for palliative care. So physical pain and symptom, psychological concerns and needs, tawakkul, faith and reliance on God and spirituality aspects, social dimension, especially social support, and burden on caregivers and their families. And I'm going to dig into these 5 dimensions in a second. And I just want to point out that other themes emerged that were extremely important for participants, which were communication and information sharing that Ghadeer is going to present in a minute, and quality of care, which is something we're still finalizing in terms of analysis. So these are the dimensions and quotes for each of the different dimensions. So I'm going to go into each of them. So physical pain and symptom is something expected in palliative care. So that was a major concern for the children, but also obviously for the caregivers. And it was highly distressing for parents to have to handle and sometimes feeling they can't address the physical pain of their child. There were also physical symptoms, and especially the loss of mobility and this inability to do what? To lose a little bit this independence that children were having was a great concern. So for example, there is a Jordanian boy aged around 11, 16 that said, I never expected the operation to be like that. I had a lot of pain and I could never move my foot. I said, it's over now. That's it. And that quote is powerful in a sense that it was connecting that physical pain and symptoms with this kind of distress they had and this kind of loss of sight on their future, and connected nicely with the next topic, which is psychological concerns for children and their caregivers. So psychological concerns and needs were extremely important. For example, this boy was saying, Jordanian boy was saying, psychology is 50% of my treatment. The way you feel and the social things that happen in your life. So for him, it was like half of his treatment was about psychology. But one thing we've seen is that participants very often had this psychological need, parents, but also the children. Even the palliative care staff knew that psychological aspects were important, but in routine practice, that was very often overlooked for various reasons. The social dimension covers social life, social activities and support, or the lack of ability to engage with this. So for example, this Turkish mother, aged 36 to 40, is sharing, we just come out and we walk around, we are not seeing anyone. In fact, that's the most important. We are going through an unsocial process. And many, many caregivers and children talked about this social isolation that they were going through because of the disease. So because they had to be away because of the disease, but also sometimes because of the way the cancer treatment worked and the fear that the child would be infected. So this kind of disconnected children and families from their normal social support and social life. And children in general were really unhappy of being isolated and not being able to play with friends or see their friends. And that Palestinian girl who was receiving care in Jordan, aged 8 to 10, she was really, she was sharing about how she was disconnected from her normal social support that she really struggled with. And she said, in Gaza, I am with my family, but here I am not. And that was a really important source of sadness and distress for the child. So that spiritual dimension looked at tawakkul, which is faith and reliance on God, and uncertainty over the future. So these were two different but very important aspects, interrelated. So tawakkul was this ability of people to use religious beliefs and religious practice to cope with the disease and all the uncertainty it was bringing, and relying that God had the best interest for them. And so kind of pushing away some of the burden into that. It was a good way of coping for most of people. That's what I would summarize. So for example, here, a Turkish grandmother in her 50s was saying, I hope Allah heals everybody and us too. If only God heals our child. And as long as the child is with me, I can accept to be beggar from door to door. And she meant here that as long as God was protecting the child and keeping the child with them, she would actually be fine with losing all the things that she had and accepted to be poor. Another huge concern for children was this uncertainty over the future and that fear that they don't have a future, that they were not able to continue their studies, have a career, have a family, especially for the teenagers, that aspect in not being able to get married and continue to higher education, for example. So that Turkish girl in her 70s, 17, 18, said, it affected my studies. I'm going to waste my future. The semester is almost over and this is hard. I don't know how I'm going to deal with that. And a lot of children were really concerned that they were not able to go to school and their whole education was disrupted. And that was for two reasons. A, because of that fear that they will lose their future, but also because that was a place for them to socialize. So all these dimensions are all interconnected, obviously. Another huge dimension that we found very relevant for our study is the burden faced by caregivers and families. And there was different types of burden. So an emotional burden that is kind of straightforward, which is that fear of losing the child, but also a financial burden. And the burden they had while thinking and planning how to care for the other siblings that very often were not with them, but stayed in another city with family or with other people that will have to support them. And they were not able to be part of their other siblings' life. So for example, this Jordanian mother in her 40s is saying, I will go to work with my heart on fire. I wait and I count the hours and I wonder when I'm going home. If they don't deduct from our salaries, I would leave work and I would sit at home with them. I have no relationships. I don't even see my neighbor. And that actually connects with that social aspect, but also with that structural issues of not being able to have care leaves for caring for a sick child. And what about the conflict setting aspects? Overall, similar concerns for caregivers and children in terms of priorities and needs, but these two dimensions of burden of families and caregivers and structural aspects were emphasized for those who were displaced, for the refugees or people who had to cross the border to seek for care. So the emotional and financial burden of being away from the family was very important, and that losing that social support in a context where people don't necessarily rely on the state offering some support was extremely important for them. Expectations in terms of care would vary depending on the country of origin and previous experiences. And another dimension that I feel is very often overlooked is all these structural barriers for refugees and people from other countries like Palestine, who had to go very often to Jordan to receive care. So there were difficulty controls shared by some parents at crossing the borders for Palestinians and seeking care. So one mother was sharing that she had to stay days in the desert at the checkpoint in the desert while having all the authorization to go and seek for care in Jordan. And they were stuck in the camp at the border. So with a child with advanced palliative care needs. Difficulties for patients in refugee camps to go physically to the treatment center because it involved getting authorization and having access to public transport. And very often there was no shuttle that will go from the refugee camp to the treatment center. But also some difficulties for healthcare professionals to visit patients in refugee camps. Also because there is a limited access to community-based care in Jordan and limited resources for that. And the final aspect is indirect cost and logistical aspects related to seeking care far away from home. So that was also for people within the countries where there is different levels of care availability within countries. So people are very often to move away from their hometown and move into a new town with all the costs that it involves, obviously financial costs, but also emotional costs and logistical aspects, like finding a house, paying for food very often was more expensive in the big city. So we had some limitations in terms of methodology. So representativity, obviously, we cannot talk necessarily for the whole region and countries, but these two centers were offering high quality care for patients. We're probably underestimating the needs here. Challenges in collecting data with children on a sensitive topic and with caregivers. So difficulty of communicating with children interviewees, especially the younger one, but also the emotional impact on the research team of such a tough topic. So what matters for children, palliative care in both countries? So pain relief and psychological support. Pain relief was more or less well addressed in these two centers, but psychological support was very often overlooked, and there needs to be that total and holistic pain taken care of by the team. So for example, a Jordanian boy in his 11 was saying, the pain, there was always pain. There was nothing good happened. Things happened all at once, my appearance changed, and I started to hate myself. And that quote is very powerful because it shows how physical but also psychological pain are all intertwined and need to be addressed all together. So what this research has, so I already talked about psychological aspects, but an important thing is we could identify children's own priority and hear their voice and try to integrate that into the care. For cultural and contextual considerations, spirituality was a coping mechanism for the children and the parents in the region. And family had a central role in decision-making. There was an important emotional and financial burden and structural barriers that I mentioned. And what we are saying is we need more psychological support for both children, young people, caregivers, but also most likely for the actual professionals providing care. An investment within countries and in the region to facilitate access to palliative care and relieve some of these structural aspects. And I think an advocacy for parents and caregivers to have paid leaves to take care for sick children and receive support when they need to relocate close to a hospital to receive care. So to go further, I put two papers and I'll share the link in the chat. We have a bit more on refugees in Jordan and a paper from Wiam Hamoudeh from Birzeit University that is fantastic on women with cancer. It's in adults, but I feel these two papers could be of interest. I'll share them in the chat. So thank you very much, and especially to the participants and the team in Turkey and Jordan. Yeah, thank you very much.
Thank you, Sabah. That was just a brilliant overview and absolutely perfect timing. So thank you so much for that. And I think you've given us just the right introduction to carry on to our second speaker, Ghadeer Alarjeh. We're so delighted to have you. You have more than 15 years experience as a palliative care nurse coordinator. You have a master's in palliative care. And in addition to your clinical experience, you are also an experienced educator and now senior researcher. So we're absolutely delighted to have you with us this morning. We're hoping very much that there's going to be excellent technical facility because we didn't get to hear you really well yesterday. So this is our chance today, and over to you.
Thank you so much. And thank you, Sabah. Thank you all for being here with us in the 7th webinar of Alarjeh. I will share my screen now. Can you see it? Can you see my screen?
Yes, thank you, Ghadeer.
Yeah. Okay, I will build on Sabah's presentation because this is a sub-analysis of the original study presented comprehensively by Sabah. So I will focus more on the results because she presented the methods in details. In this sub-analysis, we focused on communication and information sharing with the pediatric patient with advanced cancer, their caregivers, and healthcare providers in Jordan. We only used the Jordanian data to be analyzed. We all know that effective communication is very important in healthcare sector, especially in pediatric palliative care, to help in practice and enhance patient and family-centered care and quality of life. However, little is known about those strategic partners and stakeholders, communication practices, issues, and needs in Jordan. So we all know that involving those children with life-limiting disease such as cancer and immigrants, those vulnerable group of people and individual in research is very crucial and important. However, it is still limited in research field. So our aim was to provide an in-depth understanding of communication and information sharing practices, issues, and needs for pediatric patients with advanced cancer, their caregivers, and healthcare providers in Jordan. We use a sub-analysis of a qualitative cross-sectional study using semi-structured face-to-face interviews with a 3-group of stakeholders, using purposive sampling approach to recruit our participants from pediatric, palliative, inpatient, and outpatient setting at a tertiary cancer center in Jordan, which is King Hussein Cancer Center. And we sampled our group according to their age, gender, and diagnosis. We used thematic analysis and in vivo 12 software to analyze our data. In this figure, we can see the analysis track for both studies, the original one that was presented by Sabah, and this study, communication and information sharing study. In the original study, as Sabah stated, that we used the framework analysis, and in this study, we used thematic analysis to give more in-depth details about our participant views and perceptions. The 3 group, the team from Turkey, Jordan, and KCL collaborate to do and identify those themes. And the arrows in the opposite side, you see, the opposite direction, represents how the research team, move back and forth throughout the analysis phase to merge, delete, modify the themes and codes identified. Now we are going to talk about our results, our participant characteristics. 52 stakeholders were recruited, 25 pediatric patients, 15 caregivers, and 12 healthcare providers. Of those, 43 Jordanian and 9 immigrants from Palestine, Libya, and Syria were recruited. Our pediatric patient age range from 7 to 17 years old with a mean of 13.5. The caregiver's mean age was 34.7, and the healthcare provider mean age was 33 years. As Sabah also presented, majority of our participants were females, and about half of our enrolled pediatric patients had sarcoma. Regarding years of experience for our recruited and enrolled healthcare provider, it ranged between 1 and 20 years with a mean of 7.1 years. Here we can see the thematic map that we found and identify after analyzing the data. There was 4 major themes, as we can see: communication, needs, and consideration, clinical versus non-clinical information sharing, hidden information, communication and information sharing with immigrants. We are going to talk about these themes in details in the next slides. The first one was hiding information between the trading partners. After analyzing the data, we found that some parents tend to play the role of gatekeeping. So they were the gatekeepers who tend to hide certain information from their child. And also they ask some healthcare provider to also to hide information from the child in order to protect him from feeling sad or distressful. As we can see here, a 16-year-old male Jordanian pediatric patient stated that the next day he told father, and my parents kept it from me. They kept telling me it was a microbe in the blood and not to be scared. They told me my treatment would take a while. When I was admitted here, they knew I didn't know it was leukemia. So a lot of patients didn't know about their diagnosis, prognosis, treatment plan, and sometimes they were not involved in decisional process. This hiding information resulted in a mistrustful relationship between those treating partners and sometimes treatment non-compliance. Healthcare providers stated that some patients refused treatment because when they knew that their family hid certain information from them. A female non-medical healthcare provider stated that when they figure out what it is for and that they have cancer, they refuse to continue treatment. And we have a couple of cases like that. They become so upset from their parents for hiding it from them. They think about what else they have been hiding from them. They refuse treatment. We found that also some pediatric patients tend to hide their suffering and symptoms from their parents. So the healthcare provider have to come back to reassess the child when he is alone and his parents are not present. They think that they protect their family in this way. They don't want to see them sad, crying, or upset. Here, a 15-year-old female Jordanian pediatric patient said that because sometimes a child cannot talk to just anyone, especially his parents. When I talked to you earlier, I felt relieved, but I can't go and talk to my dad, and I can't tell mom everything. If I was to talk to my siblings about it, it would make them sad. I don't like seeing them sad. On the other hand, we found that some pediatric patients want to know every tiny details about their disease, their diagnosis, their prognosis. I can remember a 13-year-old Syrian refugee. She told me, I wish to be a mosquito so I can fly by the door to hear the conversation between the doctor and my parents. So she wanted to know, but her family kept it, hide it from her. While others don't want to be informed about their disease, their treatment, and they also don't want to be involved in decisional making. This 16-year-old Jordanian pediatric patient said that I came here and started getting treatment for 6 months, and I didn't know I had cancer. I owe all of this to my parents. It was a very helpful step. I still thank them for it. I tell them it is the best step they have done with me. This was surprising for me and my colleague as well, because we anticipated that all people wanted to know every details and to be participated in their decisional making. And I can remember one child told me that the doctor discussed his leg amputation with his family. And he knew months after, they refused to do it, and he knew months after, and he said he is feeling grateful that they didn't involve him in such discussion. The second major theme was communication and sharing clinical versus non-clinical information. And what we mean here by clinical, the information related to physical and medical aspects. The non-medical information, the information related to psychosocial, spiritual, and emotional information. Our results showed that some healthcare providers don't make attention to non-clinical information. They and some of the caregiver prioritized clinical information over non-clinical one. Here, a mother of 16-year-old female pediatric patient said that, I think physical issues are the most important. If a symptom is upsetting her, they should check that first. Psychological issues are not really their thing. As doctors, they should mainly think about the body and how different medication are affecting it, or if it's causing any side effect. This is a hospital, not a chapel. So there was kind of lack of awareness regarding the role of the importance of non-clinical information and issues. While other parents and pediatric patients reported that sharing such information, non-clinical information related to their social, emotional, and spiritual aspects could be helpful and could help them to feel more comfortable and to vent, and also make the healthcare provider understand their needs better. Here, a 15-year-old female Jordanian patient stated that it is important to ask about the mood, ask them about their likes and dislikes. That should be included, what they feel like doing, whether they want to play or to listen to music, or even dance and sing, or maybe to go out. The question you asked me earlier should be included because it makes some people feel bitter. So they want to be asked about non-clinical information. And on the other hand, some healthcare providers emphasize on the need to know about those issues to manage and assess the patient properly. For example, we all know the concept of total pain, and it may be induced not from physical thing. It may be from a social problem or conflict or a spiritual aspect. I can recall a healthcare provider, she told me that they face a child, he came complaining of pain, and when they dig more, they discovered that his parents are divorced and he just pretended to have pain to seek their attention. So assessing the patient from 4 domains, the physical, spiritual, psychological, emotional, is very important to manage his symptoms well. The third theme was communication needs, and we found a lot of needs in communication. Using a compassionate approach and building a trustful relationship was very important element to enhance communication. Also, sharing information proactively with the family was seen as their right, and it helped them and reassured them and decreased their level of uncertainty about things. For example, if they were informed about side effect, hair loss or something, they will know that the hair will grow again, so they feel reassured and less uncertain about the situation. Here, a 44-year-old Jordanian mother of 3-year-old pediatric patient said that it's unnatural the way she holds all of these children. You feel like she is a human in every sense of word. She gives you enough time. If you forget any question, she reminds you of them. She is unreal. When you deal with her, you wonder why there aren't more people like this. So compassionate, building trusted relationship and proactive information sharing is a very important element when communicating with those group of individuals. Also, the collaboration and coordination between staff was found very important to have effective communication and to ensure the continuity of care. So the staff used to have direct and indirect communication through meetings round in the clinic, using emails, WhatsApp or phones to deliver or to talk about the patient condition and update any new information. We should also consider the child age and medical status. Of course, the child age and developmental stage is very important aspect when communicating with a child. When you communicate with a child who is 5 years old, it's different. Use different approach, different way that is different from when you're talking with adolescents. I can remember 16-year-old Jordanian pediatric patient. He said that when he came, when he first diagnosed, he was about 10 years old, and the doctors just used Lego to explain the disease for him, and he felt very happy for that, and he suggested to use such approach with other younger kids. A 55-year-old Palestinian grandmother of 5-year-old pediatric patient said that you have to speak at the same level as that child. If you are speaking to a 5-year-old, you have to speak like a 5-year-old. And if you feel the child is smarter, you can lift up the scale. So you adapt and the approach is that appropriate to his developmental stage. Also the medical status. For example, when patients have GBM or something with his brain, his behavior may be affected and change, and he may curse or have some behavioral changes. If the healthcare provider didn't explain this to the family, they will not understand, and this will cause conflict during communication with the child and with the healthcare provider. The second consideration is parent as a facilitator in communication. So some healthcare provider and even parents stated that they can understand the patient better than anyone else. So sometimes the healthcare provider tend to ask those healthcare provider, staff about their complaints, ask the parents about their complaints and their needs, because they can understand their child better than anyone else. Also, the patient and caregiver health literacy was found to be a very important element to consider when communicating with patients and caregivers, because people may differ in their educational level and their health literacy. So you have to adapt and use different approach to be sure that the information delivered in a proper way. The fourth and the last theme was communication and information sharing with immigrants. We found that they face the same needs, the challenges and issues, and they have the same needs as the Jordanian participants. However, there's a specific aspect that we will focus on. For example, the dialect issue. Here, a healthcare provider, medical healthcare provider, stated that when the Libyans first came, it was hard to understand some of these sentences. They were saying, I remember having a Yemeni patient who I didn't know how to collect history from. It is probably due to cultural background of the patient. Other Yemeni patients were easy to talk to, but I can't generalize and say we have communication issue with them here at KHCC. The other problem or aspect, the high expectation regarding the child health status and delivered care, that may affect the communication between the staff and the family. They came with high expectation from their country, and this sometimes caused conflict between the healthcare provider and the caregivers. Here, a male medical healthcare provider stated that, I mean, the Libyan patient, do you understand how? I mean, the problem is that they don't come to us at early stage. They are all in complicated stage and in this stage, and their situation is complicated. You understand how? And the problem is that they have been told if they go to Al-Hussein Center, they will be cured, if God's will. I mean, he is coming with a belief, and you are coming to change their belief. Therefore, dealing with them is a little bit more difficult. And finally, to conclude our conclusion for this study gave us an important insight regarding communication issues and needs in pediatric palliative cancer care settings here in Jordan, especially at KHCC. Hiding information, dealing with non-clinical along with clinical information, and acknowledging and addressing immigrant dialect issues and high expectations seems to be very important to be considered. Strategic partner preferences and needs may differ and should be respected, and even the preferences may differ with time. So, for example, a child may prefer not to be told when he is 8 or 9 years old, and after maybe 2-3 years, he may change his mind. So this need have to be reassessed frequently. Understanding this aspect and treating these issues may help in improving pediatric patients and families centered care and satisfaction, and improving policy here in Jordan and hopefully all over the world. And thank you all for listening.
Absolutely wonderful. Thank you, Ghadeer. I'm so glad we got to hear that presentation fully today, and the content and the way you presented it was really brilliant. Thank you for that. And I think you're right. This has implications beyond the study setting of Jordan that you presented. Perhaps if you could stop sharing your slides now, we'll move into our discussion phase. Some people have put discussions, comments. Please do that. Please put comments into the chat, and we're going to be seeing how much we can fit in. We normally finish this webinar at 15 minutes past the hour. If you have to leave before then of course you can, but you'll be missing out, I think, on some great discussions. But we also want to welcome 2 additional panelists. We have our 2 speakers, but we also have Dr. Anwar Al-Nassan, who is a palliative care physician working since 2011 in pain and palliative care, and again in King Hussein Cancer Centre. And we also have Shireen Al-Awadi, who's a pediatric palliative care nurse coordinator, again working at King Hussein Cancer Centre. I would like to ask both of you initially just to make a comment based on those 2 presentations, and then we'll move to some of the questions that have already come up or some that will be coming up as you write in the session. So perhaps, Dr. Anwar, could I ask you just to make a comment initially?
Thank you for everything. It was great presentations from Sabah and Ghadeer. It's really very interesting what they presented, and maybe it reflects the many of the issues that we're facing here at KHCC with the refugees from different parts of the region. Now mostly they're Syrians, but we also have Iraqis, Yemenis, and Palestinians also. The main issues of the really Syrians refugees or displaced patients that we face is really at first is the financial coverage for them, and since 2013 till now things have changed. Maybe if you allow me to share 2 or 3 slides with you about these refugees, their numbers, and if you allow me to share, can I share?
As long as it's very brief, because we really want to get into the discussion. So maybe just 1 slide, just to give us an overview. Yeah,
it's a 1 slide thing. Okay.
Lovely, thank you. And
I'm sorry.
Joan, you might need to make her a co-host.
It may not be possible, Anwar. While you're thinking about that, could we please ask? Yeah, carry on. Okay. Maybe you can just tell us.
Yes, it's what I can tell you about it is that we started to receive really patients since 2010 and until now. The number of patients are increasing, and maybe the financial issues are really much settled now with the funds that we're having from St. Jude, from Gulf areas, but still. And even at first, we couldn't really keep them around. If they are treated, we either keep them inpatient because we can't have housing for them, which is really was a huge impact on the family, especially financially, because most of the time the father and the mother will stay at the hospital with both of them will stay with the child, and this means there's no financial support for the other family members, and this was a huge problem. Now, since this year, we managed to give them housing. It's a room in a hotel nearby the KHCC.
Thank you.
If you want to. Okay, if you want to have other questions, I will be happy.
Yes, that's lovely. We're just asking for a comment and then we'll have some questions. Shireen, would you like to make a just general comment and then we'll move on to the questions?
Good morning, everybody. Good morning. As Anwar mentioned, some patient cancer, especially refugee patients, have some issues about the financial, about if there is authorization to come to KHCC, because all the patients live in the camp and far away in the KHCC, and some parents refuse to treat her patients or his patients, and So some patients suffering from pain, suffering from a huge tumor. يعني as Dr. Anwar mentioned, there is some issues about patient refugee.
Thank you. Thank you for that point. And just illustrate, I see one of the issues there, combined cultural aspects, structural barriers and language. That was quite a complex interplay for immigrants. And from my work in Gaza, I know I've spoken to children there who just refuse to travel outside the country again, because being away for leukemia treatment for up to a year without being allowed to take a close family member with them because of the conditions of the siege there is just so distressing that some of the children just can't face doing that again. And as you say, I think, Sabah, you were talking about just the logistics of travel and being stuck in the Sinai on the way is just incredibly painful. So thank you for that. Now we have some questions already. Sabah, Pranab was asking about conflicts of interest. I think that's between maybe the researcher and the patients and the staff. Sounds like there's some collusion that builds up. Would you like to make any comment about any conflicts of interest you saw in this piece of research? Yeah, I asked, you're looking a bit puzzled. I think I asked him just to explain. I suspect Pranab is really talking maybe on a bigger scale about when we're having these conversations, when patients and families and healthcare workers may have different points of view. But from the research itself, because this is a tricky ethical area to do research, would you like to just comment on how you manage the ethics of this kind of research in young people?
Yeah, I think I don't think there is a straight answer, because I think there's things we may discover as we go further. So I say, sorry, I looked puzzled because I was trying to look for the question. I think, so one thing that we've seen, and probably Ghadeer touched a little bit on that, is like some people will hide information from others, and I think that thing's kind of, one of the things I think we discussed in our discussion is that definitely the research team is colleagues, or like may know some of the, not the patients, except in Turkey, for example. So we had to navigate and find a way where we don't pressure people to participate, because there is an existing connection. But actually what we've seen is that maybe it implied a selection bias, because the people who were approached were most likely those who were comfortable with being engaged further. So we might also have only good experiences, but to be honest, we actually hear bad quality story of care in that process. So overall, there's definitely a sample bias in the way that people who were familiar with the team may have been those who had the best experience, but that's not necessarily true, because the team has quite some trustful relationships. So it played in both sides. Like it also allowed to open discussions that wouldn't have been possible.
That's great. Sabah, I think that's great. I mean, I think I hear people saying it's too difficult to do this kind of research, but actually it's so important that we actually do it. And we've done some work with children in northern Uganda and refugee settings. And I think it's vital that we do tackle these ethical issues and consider them, but don't make it a barrier to doing the research. So thank you all of you for really going somewhere that is so important and isn't often covered.
Yeah. I would drop the ball to Ghadeer though, because she's the one who were physically there. I'm just a remote help in that project.
Well, I was going to just send a second question to Ghadeer, if that's all right. Ghadeer, some of the patients are a bit older. They're coming into their teenage years. And Joan has asked a very important question about sexuality. Did that come up at all in any of the discussions or themes? We didn't see it there in the themes. Ghadeer.
What do you mean by sexuality? You mean the interviewer with the pediatric patients?
No, sorry. I mean issues for the patients around sexuality. We've seen that in other research, that particularly teenagers, and this is such an important area for them, and yet difficult for them to talk about.
I think Sabah mentioned that some kids have concerns regarding their marriage or having kids in the future, but that was not that much. But some teenager said about their concern about, for example, to be married or to have kids in the future. They have such concern, but that was not mentioned by all patients. Regarding the conflict of interest, I don't know if we inform you that me and my colleague, our experience in the adult pediatric palliative care, not the adult palliative care, not pediatric palliative care. So we didn't know any of those patients. Even the healthcare provider, we don't know a lot of them because we work in a different area. We provide care for adults, not pediatrics. So we have experience in research and qualitative research, but we didn't work with pediatrics. So we don't know, there's no we didn't know anything about the participant to choose or select certain because we knew those patients will cooperate more or something. We just go there and choose those patients according to the inclusion criteria, and that's it, because we didn't know anything about them. Yeah.
Thank you, and thank you. That just is part of, for those of you new to research, that's part of the reflexive part that you do when you're doing qualitative research. I want to emphasize again, we'd love those of you who are budding researchers or who are existing researchers to join our research group in Palliative to share good practice and take these issues forward. Now to our panelists, to Anwar or Shireen, whichever you want to answer. I was just really struck by the role of the palliative care worker, the compassionate input, the need to have pretty excellent communication skills if you're going to navigate some patients who want to know, some who don't want to know, parents who might feel differently. Could you just comment on how that happens in practice? Because I know you're both clinicians, how we handle those very important interactions for holistic care and communication. Dr. Anwar, would you be happy to? Yeah, thank you.
Yes, thank you for this important question. Actually, our center is called King Hussein Cancer Center. So no single child comes to this center. They know that this is a cancer center. And even the very young children, the toddlers even, they know this is a cancer center. The other thing, when they come to the palliative care, most of them, they express that they stopped all the treatment for us, why we are here. They might ask this question. Sometimes the family, when the caregiver, either the parents or one of the parents will step forward to the clinic before the child comes in and clears it up for us that they do not want that the child knows that they are palliative patients. So it really depends. What we do with these children, usually we listen to them carefully. We talk to them, we go through all the signs and symptoms and everything. Now, if we were asked directly if they are palliative, we will say, yes, you are palliative. If they are not asking us directly, we will not volunteer to tell them this information. And this is built up with us through the experience, through our communities, through the Arab and Muslim community. It's not only the Jordanian community, the Syrians, the Libyans, the Yemenis, all who we encountered, the family preference, and most of the times they wouldn't like to tell that their child is palliative. Of course, the teenagers, they're a different story, and some of them would like to come to the clinic by themselves. They wouldn't like to be accompanied by their families. And through my experience, few patients, they ask the question directly, and many of them, they knew it, but they wouldn't express it. But they deep inside, they know they are palliative patients. And this is how things are run. We keep them at their preference.
Okay,
and
thank you.
Usually, so we do, because if we tell the truth as it is, we might lose the patients and the caregivers.
Sure. I think you're describing so well that that's actually a very sophisticated interaction, and with the experience that you have, I'm sure you're able to do that. But it is something we need to remember to focus on in our training for those who are not so experienced, for sure. Thank you for that, Sabah. Can I come back to you then? We've had these comments in the chat about collaborative cross-border approaches, and I know you also are part of this group in Manchester looking at particularly at conflict and humanitarian settings from a global health point of view. Would you like to just make some comments on those issues, Sabah?
Yes, I think I'm thanking the team very much because they embarked on a completely crazy idea. So I'm new in palliative care, and the team is extremely experienced and come from different backgrounds. So as I started to receive all this data, I was like, I'm definitely having one perspective on it, which is global health epidemiology. And they came from different aspects. So as I went through, I was like, no, we can't do the normal classic approach with just me coding data that are not coming from my interviews. So then I embarked them into a new method that we've developed basically but so basically we all had randomly allocated interviews to code. So then everybody generated themes that they thought were just matching the data, right? And then we had to spend hours, but by hours, I probably will get close to 30 hours of Zoom to make sense of what we meant, where we're going from, what do you mean, what does it mean in Turkey, what does it mean in Jordan. So it was extremely time consuming, but for me it was good because it was locked down. So to be honest, it was amazing to have people to talk through on Zoom. So it ended up being extremely good, and we have a huge database now. We just don't have time and resources to just finalize all the work we have. But basically what it allowed is like capture all the diversity of this experience and the different perspectives, but also understand what it really meant. Because then I was like, oh, that's what they're saying. And they're like, no, you don't understand. Like in Jordan, that's what it means. I was like, oh, okay, cool. And then we like created a dictionary kind of what all this concept means. So it's really good, as in it's good quality research. But to be honest, the funding restriction and the time we have to do research properly is limited. So I would say it's difficult. It was amazing to do. And thank you, Ghadeer, and all the others who helped with that. I think it's the best way, but in practicalities, it's really challenging.
Thank you so much. And just on behalf of the wider humanitarian family, I want to thank King Hussein Cancer Centre because you're focusing on your clinical work today, for the amazing work you do for people who get to you, even though it's a difficult journey to get to you for many, many patients. Thank you for telling us, Shireen and Anwar, about the hotel and for the way in which you're caring for the migrants as well as the population of Jordan, so many of whom are migrants as well. So thank you for that. It's such an important resource in the region. We just have a few minutes towards the end. Shireen, I wonder if there's anything you would like to comment on. Just conscious we haven't heard from Shireen so much. While Shireen's preparing to see if she can comment, please do join PalChase. We would love to invigorate our research working group and other groups. Pranab, I see you're going to join the advocacy group. Shireen maybe isn't able to hear me this morning. Okay, I think we've also identified ways in which we can put this research, even at the stage it's at now, into practice. So I think we've already been touching on that, haven't we? Advocacy, training, clinical skills, and the way in which we communicate and interact with patients. Hugely, hugely important. I just flag up that many people can't cross borders. So Joan, absolutely, the Ukraine experience has been amazing as people have been able to move out from Gaza. That is simply not possible. And I'm delighted also to say that we're going to be launching a diploma in palliative care next month, all being well. If any of you want to join with that, please also be in touch and let us know, because it would be lovely to build the expertise there and to continue to develop this. I think just with a few minutes to go. Yes, Erin.
Oh, sorry, I think you just cut out as you said the thing that you would like us all to join. Sorry.
What I was saying was that we'll be starting with our colleagues in Gaza a diploma in palliative care, distance learning, because they can't travel, also for training. So we're just saying if anyone wants to be involved with that, please do also contact us. Be lovely to hear from you. And Anwar, great, you're keen to join the research group. Please click on the link. And the link, you've got two links there, one for webinar feedback and one for joining Palchase. Palchase is a network. It's very much there to showcase good practice like we've done today with the fantastic work that's been presented today. It's also a network that helps develop and support educational impact as well as research, advocacy, and also to build connections between global health and palliative care and the humanitarian sector. And I see not so many people have joined us again from the humanitarian sector. If anybody knows people from that sector, please encourage them, because I think we're richer together as we understand and listen to one another and think of how we can apply these situations more broadly to our own settings. We also have a blog and we love to showcase. So I think we'll not only be sharing these webinars, but Ghadeer and Sabah, we maybe be asking you to contribute to that blog so that we can just share and extend that a bit further. These recordings will be on the website. Just wait a little bit and they'll be there. And we look forward to working with you in the future. I think unless there's any last comments anyone wants to just make, we've just got, I think, 2 minutes. Joan,
Moira, I know yesterday we had a lot of questions, and I think there was one you wanted to follow up on related to.
We did.
Wasn't it on the healthcare worker?
It's all right. We followed up on the ones I wanted to. That's all right. Yeah,
okay.
Thanks, Ellen. Joan, you want to make a last comment? Joan's joining from a phone. It's difficult for her. Okay. So thank you, everyone. Ghadeer, Sabah, Anwar, Shireen, thank you so much for joining us. Everybody else, thank you for being part of this. We had around 50 yesterday, around 30, or 20 to 30 today. It's been just brilliant to showcase this amazing research and to discuss better how we can take these research findings and look at what that means for our experience, our work experience, our research experience, and our education experience. Thank you for that. And we wish you a very good day if it's the morning, or if it's later in the day, a very good evening. Thank you so much.
Thank you, everyone.